so much for this nice introduction. It's truly an honor and a pleasure to be here. Thank you for the invitation to present our research. So my interest, I'm trying to actually adjust this. So my interest is in evaluating vocal fold vibratory characteristics that are affected in individuals with spasmodic dysphonia. So for any kind of clinical evaluation, we use a battery of tests to arrive at a diagnosis of a condition. And as Dr. Bastian mentioned, this battery of tests includes case history, laryngeal imaging, sometimes some acoustic analysis, aerodynamic analysis. And really, based on this battery of tests, we arrive at a diagnosis. And in this, really, laryngeal imaging is critical, where we are kind of looking at vocal folds, how they're moving, if there are any structural abnormalities. And based on the movement of the vocal fold vibrations, specific kind of treatments are recommended. So the current clinical battery of tests that we use for evaluation in the clinic, they have some limitations because each of these tests, they are based on some specific principles. In terms of evaluating vocal fold function, by vocal fold function, I mean how the vocal folds are vibrating. So you know that air from the lungs comes to the level of the vocal folds, and then the vocal folds open, close, and smoothly oscillate. That's kind of normal vibration. But when there is spasmodic dysphonia, the vocal folds kind of don't smoothly open and close. They kind of break, or they kind of have small amplitude. So there is kind of this whole range of disturbance in the opening and closing of the vocal folds. So stroboscopy is a system which is a gold standard in laryngeal imaging, and that can be done with a scope in the mouth or the nose. And here is how normal oscillation looks like. So you can see the smooth opening and closing of the vocal folds. I think I have sound So this stroboscopy really works well when voice is normal or mildly affected and moderately affected. But because stroboscopy only produces an average movement of the vocal folds, it doesn't work well when voice is severely affected. So with average vocal fold motion, what I mean is that when the vocal folds are vibrating, we want to capture each and every cycle of vocal fold vibration. But what stroboscopy does is you often have like a laryngeal microphone we need to hold on the neck, and that kind of picks up the pitch of the voice, which in turn triggers the strobe light and kind of slows this movement of the vocal folds. So vocal folds vibrate like in females like around 200 times a second, and in males around 120, 100 times a second. So this is very, very fast, and our eye cannot see it. So we slow it down with this kind of technique called stroboscopy, where you see kind of an average motion. But when voice is severely affected, the laryngeal microphone really cannot capture the pitch of the voice. And so it in turn does not really trigger the strobe light to latch onto something kind of which is steady. And so what you see is kind of an artifact. And so this is where an individual has severe spasmodic dysphonia and a little bit of tremor. And you can see some of the static kind of patterns in terms of the compressions and the breaks, but not much in terms of vocal fold vibrations. So I'll play this. So you can see kind of the spasms and kind of adduction like that. But this is high-speed imaging of the same individual, which was captured for the same E phonation. And this high speed records vocal folds movements at 4,000 frames per second, whereas stroboscopy captures vocal folds motion at 30 frames per second. So we have this really high resolution in terms of frequency to capture vibrations. So we cannot see all 4,000 frames a second, so I have to slow the videos down. And so now this is going to play at 15 frames per second. And you can see just in that you have now kind of normal oscillation for a little bit. And then you'll see that all of a sudden there is a spasm, which is a break where vocal folds would just stop phonating. This is all in just that E that you just heard. And you see that these breaks are not in the completely adductive position, meaning the vocal folds, there is a small gap, and then they will start kind of vibrating again. So we see all these variations just in like a 2-second sample of phonation. What we thought is we would do a study where to see if we could identify different kind of patterns of vocal fold vibratory disturbances within individuals with spasmodic dysphonia. So we did a study on that. But this is just a slide that shows what stroboscopy is doing. So it's not capturing each and every cycle. It just flashes light on specific segments here of the cycle and then fuses them to form kind of this average kind of motion. So here is a slide. So one glottal cycle consists of, like, say, open phase, and then slowly the vocal folds close, and then they begin to open, and this kind of continues in time as one says E. This is, of course, normal phonation. So with high speed, for just one cycle, you can get about 13 frames. So everything that is in kind of blue and gray is being missed by stroboscopy. The stroboscopy flashes are in kind of these red boxes here. So this here is a schematic of the previous slide where in 21 actual glottal cycles with strobe in normal voice, we get about half a cycle because it averages motion, whereas with high speed, for one cycle, we can get 13 frames. So we have this detailed information. And so in our initial study, we did a study with 11 individuals with adductive spasmodic dysphonia, 11 with muscle tension dysphonia, and then we had age and gender match control groups. We chose muscle tension dysphonia for obvious reasons that, sometimes clinically it is hard to differentiate the two conditions. So here is again just what normal vocal fold vibrations kind of look on high speed. And it's not going to play, but it's just kind of a smooth opening, closing. And with image processing, we can kind of trace the glottis. And so you can see here this graph, it's kind of smooth opening, closing. So this is the opening, and here the vocal folds are maximum open, closing, and then this is the closed phase. And then based on this pattern, we can kind of quantify how the vocal folds are moving. So in terms of all the irregularities, we wanted to quantify what the motion irregularities are. So this is kind of normal voice. This is all on sustained phonation. Motion irregularities we define as kind of cycles that are not similar in height and shape. Then we also tried to identify the type of the oscillatory breaks that we saw. So are the vocal folds in the completely closed position? Are they slightly in the open position? Because based on that configuration, we can potentially identify some of the muscles that might be affected. So the vocal folds vibrations kind of grossly are controlled by like 5 intrinsic muscles. There is one that opens the vocal folds, and there are 4 that kind of close the vocal folds. So based on what the configuration is during a break, we could kind of visually detect potentially what muscle could be affected. So here, in terms of a break, it's generally kind of a straight line where there is no vocal cord vibrations. And then we have some things that we call micromotion, which I will get into a little bit. So here is an example of a break where the vocal cords are closed. This here in the bottom is just vibrations of like one line, which kind of is a typical line across, horizontal line. So you can see there are some normal oscillations here, and here, there are kind of some irregularities, and then here is kind of the straight line, which is kind of the voice break. Here, the vocal folds are spasming in kind of a slightly abducted position. Here, the pitch of the voice is very high, so you see that the vocal folds are really tense, and there is small amplitude of motion. So with this pattern, we can kind of say that it is predominantly the CT muscle, which is the cricothyroid muscle, which is responsible for increase in the pitch of the voice. And you see that now the vocal folds spasm, and then they will start kind of vibrating normally again. But here now there is a complete gap between the vocal folds. All of these individuals were identified as adductor spasmodic dysphonia on neurologic evaluation or neurological examination. And here is like another example which you just saw, that the vocal folds are vibrating, and then slowly, this is kind of normal vibratory pattern, then kind of they remain open, and then there is a break right there. And then they start moving normally again. Micro motions are kind of small vibratory motions of the edges. They usually precede a break. So here the larynx is kind of going lower in the plane compared to the normal plane. And then you see these small, right now, these edge movements. That's not full oscillation with the cover and body, but it's just small kind of micro motions of the vocal cord edges. And then we looked at various kind of hyperfunction behavior because we have the muscle tension dysphonia group as well. So what we found were that between these two groups, we saw distinct vibratory patterns. In muscle tension dysphonia group, the vibration was affected, but they never kind of spasmed, or they never had micromotions. So I'm going to play this so you can hear the sound, and you will hear a diplophonia, which is kind of two pitches.
Okay, glide down your pitch range for me. It's from high to low.
And there you can hear the diplophonia. You can even see a little bit of the vibrations here, which were aperiodic. And this is during the same session, and you can see that the tissues are really nice and pliable, but they're not oscillating normally. So there is an asymmetry laterally as well as anterior posteriorly. And then we quantified this waveform here where you have one normal cycle and a bifurcation that's typically off like when you have two pitches. So in muscle tension dysphonia, we saw one pattern and that remained consistent throughout. Whereas in individuals with spasmodic dysphonia, there were either breaks or there were kind of a lot of aperiodicities, but the pattern was not always consistent throughout vocal cord vibration. This was another individual where with muscle tension dysphonia with a pressed vocal fry kind of pattern.
Take a breath. E. Okay, I want you to be louder. E.
So here you can see some flutter, but the voice is so aperiodic that the stroboscopy is not actually tracking the entire vibrations. And here you can see that there are like two small openings followed by a long closed phase, and this kind of vibration kind of repeats in time. So that's kind of a vocal fry type of pattern. So what we found was in this study that individuals with adductor spasmodic dysphonia had more like motion irregularities, micromotions. 36% of them had breaks, not all of them had breaks. But in terms of breaks, we were able to identify breaks as small as 8 milliseconds. And these breaks did not always happen in the closed position. So sometimes the vocal folds remained open, even if it was adductor spasmodic dysphonia. And in muscle tension dysphonia individuals, we did not see breaks, we did not see micromotions. We saw hyperfunction behavior and atypical but consistent vibratory patterns. So with this study, if we have a rule that if micromotions were greater than 5 and if there was a voice break that was present, then with high-speed imaging we could identify adductor spasmodic dysphonia about 80% of the time. So in our next study, we wanted to see are these voice breaks and different kind of vibratory patterns that we see in adductor spasmodic dysphonia correlate with the abnormalities of the spasms in the muscle from laryngeal EMG. So we did a study where we would perform simultaneous laryngeal EMG and high-speed imaging. So this is our setup where this is kind of the laryngeal imaging system. We did hook wire laryngeal EMG, which are those fine wires that Dr. Mo showed. And they were inserted into the thyroidrythmoid muscle, the cricothyroid muscle, and the posterior cricothyroid muscles. And for this study, we've so far recruited 9 individuals with adductor spasmodic dysphonia and 11 healthy individuals with no voice problems. And here you can see this is normal voice. This is simultaneous high-speed imaging with laryngeal EMG. So for normal voice, here is the TA muscle, thyroidrythmoid muscle is in green. So the muscle is activated, and then the red is the audio signal. So muscle activates before, like 50 to 200 milliseconds prior to the onset of voicing. And then the blue line here is the cricothyroid muscle, so that was not active in that case. And then this is the PCA, the posterior cricothyroid muscle. So before the voicing is started, the vocal folds are open, they close. So that is kind of active prior. And here is kind of the adductor spasmodic dysphonia, and where you can see that there are kind of spasms, and here there is a small spasm. Here you see a spasm and sustained phonation. This is unprocessed EMG. This is the thyroidrythmoid muscle, and this here is the cricothyroid muscle. So what we see here is that in individuals with adductor spasmodic dysphonia, we were able to identify these muscle spasms prior to the voice break. So the red is the laryngeal EMG, and then this blue turquoise color is the vocal fold vibrations from high-speed imaging. And then in this 9 subjects, 3 individuals did not have any breaks, and their vocal fold vibrations looked very smooth, and they did not have these spasms in laryngeal EMG. And in the control group, also, it's nice vocal cord vibration and no spasms. So we identified spasms as activity that is greater compared in the 50 to 100 milliseconds window. We found these EMG bursts in about 82% of the individuals that had the break. And these bursts were not identified in normal individuals, and in ADSD where they did not have breaks, and also when the voice is smooth, these bursts were not present. And then in our second part, we are looking at what is the duration of the muscle activation and starting of voicing. So here you see an E sound that's just being started. So the vocal folds are going to close, and you'll see some small vibratory motions of the edge. And after that, the vibrations will become much more sustained and periodic. So they're closing, so the PCA was active, now the TA is active, and then the voicing will start a little bit. And the CT was not active at all, this is normal voice. So now you'll see kind of small vibratory motions here, and then it will be kind of smooth, sustained oscillations. In individuals with adductor spasmodic dysphonia, you can tell from this audio signal that there is a long time from the start of one E to the next E. So this is E, E, E done kind of consecutively. We found that the latency, which is kind of the time that the muscle gets the signal to when the vocal cord vibration starts, is longer in individuals with adductor spasmodic dysphonia. So now we are kind of looking to see why is this longer? Is this longer because the muscle does not stop activating, so is it just firing for a long period of time? Or are there contractions of other muscles? So is the TA active and is the CT active at the same time? Then that will give us an indication of the clinical pathophysiology of why this is happening. So in summary, with high-speed imaging, we can visualize and potentially, maybe with large number of subjects, can actually classify the various fine vibratory patterns that Dr. Bastian so kind of beautifully demonstrated. And we know that Botox generally is injected, as Dr. Burke mentioned, in the thyroid-rhythmoid muscle, but in some individuals, that is not sufficient. Sometimes it is the TA plus the LCA or TA plus the CT a little bit. So if we can really identify these specific abnormalities, then we can better target treatment until we really find out what is affected in the brain and if there is a specific gene that's being affected. Thank you. And I want to acknowledge my research team and all the patients who participated in this study. It's a long study, it takes at least 2 hours to get through. The laryngeal EMG is kind of the tricky part with all the needles kind of that go in. I want to thank Ed Matthews and the Indiana Spasmodic Dysphonia Support Group for all their help with